Remember when it was a simpler time and the simple question was, who moved my cheese? Your cheese has probably been moved, removed, stomped up and down, steamrollered, sent back to you, and it doesn't look anything like your cheese anymore. We're at the Cardiovascular Summit trying to thrive in some real times of change here at the ACC. And I am with the keynote speaker again this year, Harold Miller, who is President and CEO of the Center for Healthcare Quality and Payment Reform. This has always seemed like a lose-lose-lose situation as we get through the healthcare reform deal, but you're saying this is a win-win-win situation for in the case of accountable care. How can you be so optimistic, number one? Number two, what's your main message that you're trying to get across?
Well, I'm optimistic because I think that you can get win-win-win approaches if the physicians actually are in the lead. Most situations turn into win-lose structures because it's health plans that are basically trying to make money at the expense of physicians and patients. And so if the physicians can actually take control, they're the ones that know how you can redesign care in a way that can be better for patients and be able to save money for the true purchasers, Medicare, for employers, et cetera. The problem is that physicians they're busy taking care of patients. They have to step back a little bit and say, how can we actually take control of the system, redesign it so that it's actually more affordable as well as better for the patients? And that's how you get a win-win-win. A win for the patients, a win for the payers, and a win for the physicians.
This is not going to be easy, however. I mean, we know how many hours it takes to just get your clinical job done when you throw in administrative tasks on top of it. How difficult is it for most doctors? What can they do?
Well, it's hard, but the question is it easy to do what you're doing today, to be facing potential for a 25% reimbursement cut from Medicare, to be dealing with all kinds of utilization reviews and radiology benefit managers and other kinds of micromanagement that comes from health plans? That's also taking doctors' time, and their practices are spending a lot of time just trying to fight adjudication battles over claims. So one of the advantages of trying to have a different approach and a different way to pay physicians is to take away all of that administrative burden and let them be able to actually spend more time focusing on patients and be able to do that in a way that saves money. But it requires, like any business, you have to take some time away from the way you're doing things now to reinvent things. And that's, I think, really the challenge for cardiologists, is to find that time and the willingness to take time away to be able to redesign the system so that it's better in the long run. Temporary inconvenience, permanent improvement, hopefully.
Now that 2013 is behind us and it was an interesting year, does 2014 look like it's going to be any stabler? What lessons can be taken into this year?
I actually hope it's not going to be stable, because if it's stable, it means it's going to be the same as it has been in the past, and what has been in the past is not very good. I think the issue is, will 2014 be unstable but get to a better resolution? So Congress was trying to fix the sustainable growth rate last year and didn't. But the legislation, the good news about the legislation is that it's not just trying to repeal the SGR, it's also hopefully going to give opportunities for different ways for cardiologists to be paid that actually enable them to come out ahead and with their patients come out ahead in ways that the current ways of paying doctors do not do. Because today, if physicians actually do the kinds of things that the ACC has been a pioneer in developing appropriate use criteria, et cetera, doctors will lose money, even though where most of the savings is coming from is not the physicians, it's coming from hospitals and other places. So having a different way of paying cardiologists would enable them to deliver more appropriate care for patients and in a way that doesn't hurt them financially.
I mean, you've set out, I think, last year when we were talking about the fact that so much of the changes that were proposed were ones that would pit doctors against pharmaceutical companies, against hospitals, against device manufacturers. Is there going to be a little less pit and a little bit more substance this year?
Well, I think that right now physicians end up being at the bottom of the food chain on everything, and everybody gets their money first. So the health plans get their money, and the pharmaceutical companies get their money, and the hospitals get their money. I think that the opportunity is that by having physicians be in the lead who can really redesign care, you can find a way to do it, as I described, in a win-win-win fashion. And one of the things I'll be talking about in the presentation is how even hospitals can come out ahead. The issue is that what winning in the future means for a hospital is different than what it means today. Today, winning for a hospital means getting more volume and more revenues, because that's the only way they can increase their margins. In the future, the opportunity is to pay hospitals differently so that they can actually improve their margins without having to get higher volume, because that's really what we want to be able to do, is to be able to do the right thing for patients, not necessarily more things for patients.
So what's the best thing that a doctor can do right now, particularly one who's rather frustrated at how the system is working, or not, as the case may be?
I think number one is to tell the leadership of the American College of Cardiology that this should be one of the top priorities for the college, is to work on developing better payment models for physicians and getting them implemented. I think number two is to call your congressmen and senators and say physicians actually want to take accountability for controlling costs, and they can do it a whole lot better than anybody else can, but they need to be paid in a way that enables them to support that. And then I think a third thing is to go and start talking to the purchasers in their own community, the employers, about how to help them, not just talk to health plans, to go directly to the purchasers. And in many cases today, the direct purchasers are becoming the patients themselves with high deductible health plans. So I think that more direct relationships between physicians and the people who are actually purchasing the care could make a dramatic difference in the way care is delivered.
This road from volume to value is a little bumpy.
It's very bumpy, but today's system is not exactly what anybody would call easy or pleasant. So I think that's the challenge, is there may be some potholes along the way, hopefully no broken axles, but that by the time you get to the end of it, it will be a much better place to be. And again, I think that we've tried everything else. What we haven't really tried is to say, let's have the physicians, who are the ones who actually know what the patients need and the best way to deliver care, to have them actually take the lead in doing this rather than having other people do that.
I mean, last year out of this meeting, we did a cover story on the Valley of Death, which is where the whole industry seems to be moving through right now. How far are we through the Valley of Death?
To tell you the truth, I think we're only very much at the beginning of the transition. I think that the death part is actually worse now because we are using payment models and structures that actually make it worse for physicians. For example, the shared savings model, which Medicare and a lot of private payers have been using, is promoted as actually being better for doctors and hospitals, easier to do. It's actually worse, because what they will end up doing is generating short-term savings that will then ultimately all go back to the payers, and the payers will say, what else are you going to do for us now? So I think that the challenge is, if physicians and hospitals can actually move to better payment models now, that short-term pain will actually then enable them to be more successful in the long run, rather than just being one temporary giveaway to payers, and then they have to come back to the table to do even more.
So again, we're at the Cardiovascular Summit here in Las Vegas for 2014. Please see our coverage in CSWN as well as online. For CardioSource World News, I'm Executive Editor Rick McGuire.